Hi, my name is Ananya Das. I'm one of the Associate Editors of Gastrointestinal Endoscopy. I'm here to talk and discuss with Dr. Sachin Wani. He is an assistant professor from University of Colorado. Dr. Wani did work on a very beautiful project on diagnostic yield of malignancy during endoscopic ultrasound guided fine needle aspiration with and without a stylet. That was a prospective randomized trial which has been accepted for publication in our journal. And I'd like to thank Dr. Wani to be here and the opportunity to talk to you about this paper in a little bit more detail.
Thanks, Ananya. Thank you for the invitation.
Sure, thank you. So, looks like this work that you did when you are in University of Washington University, right?
That's right. That's right.
And tell us a little bit the summary of the paper that
Absolutely.
Why you did it, what did you do, and what you came out with.
Sure, absolutely. The real driving force behind this project was based on the fact that most endosonographers use a stylet during EUS-FNA, and there's really no good data to suggest that use of a stylet improves the diagnostic yield of malignancy or has any impact on the cytologic characteristics of our FNA specimens. And there are observational and pilot data that have shown the opposite, where the amount of blood in specimens may actually be higher when you use a stylet. And again, there's been no difference in the diagnostic yield of malignancy between the two methods. So that was really the driving force. This study was a randomized controlled trial that was conducted at a tertiary referral center where consecutive patients with a solid lesion were referred for an EUS-FNA. And our primary aim was to compare these two methods of obtaining EUS-FNA specimens with and without a stylet. And our primary outcome was the diagnostic yield of malignancy between these two groups, which is really the main reason why we do EUS-FNA. And in addition, our secondary outcomes were to compare cytologic characteristics such as adequacy of specimens, cellularity, amount of blood, and contamination. So we used pre-printed randomization sequences where patients with a pancreatic mass underwent 6 passes, 3 with a stylet and 3 without a stylet. For lymph nodes, we performed 4 passes, 2 with stylet and 2 without a stylet. And at the end, the cytopathologist actually evaluated all these specimens and were completely blinded to the technique of EUS, and they compared the specimens for these outcomes that I just mentioned. In total, we recruited 100 patients, which were included for the final analysis. 37 patients did not meet the criteria for the study, and our main results were that there was no difference in the diagnostic yield of malignancy for passes done with a stylet and those without a stylet. Similarly, we found no difference in all the cytologic characteristics that I mentioned, i.e. cellularity, adequacy, amount of blood, and contamination.
Very good, yeah. I read the paper, and methodology is really very good and very well conducted.
Thank you.
Close to an ideal randomized study that it should be. One of the questions come up, I do see that the original sample size calculation was quite high,
Right.
And then you decided to stop the study when you reached the number where you thought that you will have a reasonable conclusion. So is that valid? Do you have any concern about the sample size?
I think that's a very valid point. In our original protocol, we did not have a stopping rule or a rule for interim analysis. Really, the impetus to do an interim analysis was based on a recent randomized control trial that showed no difference, and we as endosonographers had this feeling that there was not going to be a difference, but we really used the cutoff of 100 patients based on a recent randomized control trial. I think your concerns about a type 2 error, not having enough patients, is a legitimate one. So we also did futility calculations, and even though our conditional power was high, we calculated the number of patients that we would have to recruit to detect any possible difference difference, and that number was more than 4,000. And as an investigator, you know, to recruit 4,000 patients for a project like this would be practically impossible.
Yes. The other point is that, obviously you blinded the cytologist, which is a very good idea, and easy to do. But obviously you cannot blind the endosonographer.
Absolutely.
I'm not sure how can you do that.
Right.
But did you collect any feedback from the endosonographers that were doing it? Because some of us, sometimes particularly a hard lesion to penetrate it, we think the stylet kind of stabilizes the needle a little bit. So did you collect any feedback, general feedback? Was there any difference in perception, the feel of the procedure?
No, that's a very valid point, and that's probably one of the limitations. We never really got any feedback from the endosonographer, but at least I can vouch for all the co-investigators on this study. We all feel that really a stylet really makes no difference. The only time we've used a stylet is when it's hard to express the specimen out of the needle, but getting true feedback from the endosonographer was something that we didn't do in our study.
And I guess the main objective is to not to use the stylet, is to increase the efficiency of the whole procedure.
Right.
And I'm sure that the GI technicians will be very happy because they don't have to
struggle
it with this pushing and pulling the stylet. But did you have any kind of an idea, subjective or objective, whether it really shortens the time and increases the efficiency of the...
Right. No, I think, again, this is a very valid point, and it can be included as one of our limitations because we really did not do a time calculation in our study. But to do a time calculation for this study would be really difficult to do. So you would have to measure the time that you took for one pass, which was with a stylet, the second pass, which may have been without a stylet. So to actually define at what point do you start, the time calculation would be really difficult to do, but it's our feeling that not using a stylet may not really have that much of a time difference for one case. But if you have a busy EUS practice where you're doing 7, 8, maybe 10 cases in a day, I think it all adds up at the end.
Sure, it does. Now, one last question.
Sure.
What's the next step? Is there a next step?
I don't think there's a next step. I think there's enough data. Now we have level 1 evidence that shows that use of a stylet really has no impact on the diagnostic yield of malignancy. So, and I think that's the gold standard. That's what you're looking for. So I feel fairly comfortable saying that you should not be using a stylet.
I agree. Endoscopic ultrasound has become a very, very common procedure, and it's so interesting that how scientifically we strive to get every little small answered in a very scientific fashion and get to the point. But thank you for being here.
Thank you,
That's really very nice. Congratulations
really
for getting
the
the paper accepted.
Thank you.